Welcome, dear audience, to another session of our international educational series. Today, we are going to talk about visual rehabilitation, particularly in diseases which affect central vision and severely affect the vision of patients. Especially, we have chosen the disease age-related macular degeneration, which affects aged people and affect their central vision. How their vision can be rehabilitated and how can they use the residual and available vision to carry out their day-to-day activities. In order to discuss this, we have invited today Dr. Nadia Fernandez. Dr. Nadia Fernandez is an orthoptist. She is a lecturer in Lisbon School of Health and Technology. Her clinical practice focuses on visual rehabilitation, vision health promotion, binocular vision assessment, and diagnostic ophthalmic testing. She basically integrates lifestyle-based changes, interventions with visual rehabilitation strategies to enhance functional outcomes and promote overall patient well-being. We are very thankful to Dr. Nadia Fernandez for accepting our invitation and presenting the talk on this very challenging topic of visual rehabilitation in age-related macular degeneration.
Okay. Good morning. I'd like to thank Dr. Ali Mirza for this invitation. My name is Nadia Fernandes, and my topic for today is integrated visual rehabilitation in age-related macular degeneration. AMD is one of the leading causes of visual impairment in older adults, and its impact goes far beyond visual acuity, affecting daily functioning, independence, and quality of life. In this talk, I will focus on how integrated visual rehabilitation strategies can help patients maximize their remaining vision and maintaining functional independence. Before starting, I would like to disclose that I have no conflict of interest with this presentation. First, I will briefly discuss the functional impact of AMD and why early referral is so important to vision rehabilitation. Then I will review functional and structural assessment, including biomarkers that help guide rehabilitation planning. Next, I will present practical rehabilitation strategies used in clinical practice, including PREL rehabilitation and low vision devices. And finally, I will highlight the importance of patient education, lifestyle intervention, and key clinical take-home messages for conclude. So, functional impact of AMD and the importance of early referral to visual rehabilitation is very important in our clinical practice because AMD patients may experience central visual loss, reading and face recognition difficulties, and decreased quality of life and increased depression risk. So early referral maximizes remaining vision and promotes patient independence. When managing AMD patients, do we focus only on the disease or also on the patient's functional vision and lifestyle? This is an important question because AMD is the most common acquired maculopathy in older adults, not only in elderly, but also in adults in active life. So affects more women more frequently and increasingly prevalent due to aging, systemic, and lifestyle factors. Low vision rehabilitation has a positive impact on reading and depression management, reduces socioeconomic burden, and early intervention is recommended for improved quality of life. Integrated visual rehabilitation combined with lifestyle intervention such as adherence to Mediterranean diet or smoking cessation, represents a promising strategy to improve functional vision and potentially delay AMD risk of progression. AMD primarily affects central vision, which is essential for tasks such as reading, recognize faces, and driving. Patients may experience a central scotoma and metamorphopsia, a reduced visual acuity and contrast sensitivity, as reading ability and face recognition, and this loss of independence in daily tasks, such as driving, medication management, or cooking, can affect significantly and impact negatively the quality of life. But the impact, it's not only visual. So patients with AMD have a high risk of depression and anxiety, social isolation, fear of falls, functional disability, even with moderate visual acuity loss, not only with profound or severe visual acuity loss, association with increased risk of cognitive impairment or dementia, and this loss can affect quality of life and functional ability. So, one of the key messages of this presentation is that visual rehabilitation should start early, not only when vision is severely reduced. Early referral allows better visual adaptation to vision loss, development of compensatory strategies such as eccentric viewing training or a stabilization of preferred retinal locus, and prevention of functional decline through use of residual visual. Importantly, rehabilitation can begin even while medical treatment is ongoing, including anti-VEGF therapy. Effective visual rehabilitation requires a multidisciplinary approach. This usually involves a collaboration between ophthalmologists, orthoptists, optometrists, low vision specialists, occupation therapists, and psychologists and social worker, because this integrated model ensures that both medical and functional aspects of vision loss are addressed. Visual rehabilitation begins with a comprehensive assessment that includes not only visual acuity but also functional vision measures such as reading ability, contrast sensitivity, and central visual field performance. The goal is restore independence, improve quality of life, and reduce social burden. Our approach is a patient-centered rehabilitation in AMD because it's possible to tailor strategies based on visual function, lifestyle, and patient needs, integration with medical management through a coordination between ophthalmologists and rehabilitation professionals, follow-up during anti-VEGF therapy, and a continuous monitoring and follow-up through assessment of visual function over time and monitoring disease progression, because AMD has different types, dry or neovascular, in different stages, so it's important to know about it. And structural biomarkers obtained from multimodal imaging also play an important role in low vision rehabilitation because they help us to AMD progression predictors that enabling early rehabilitation planning. They promote a functional correlation because some of changes are associated with reduced retinal sensitivity and early functional impairment, often preceding significant visual acuity loss, and help us treatment monitoring because SD-OCT is the gold standard for monitoring neovascular AMD response to anti-VEGF therapy. For example, we have a structural biomarkers associated with functional prognosis. For example, ellipsoid zone integrity, retinal pigmentary epithelium alterations, subretinal drusenoid deposits, and geographic atrophy extent. These biomarkers help predict functional prognosis and guide individualized rehabilitation strategies. So, preferred retinal locus. When central vision is damaged, patients may develop a new fovea, some like a new fovea, a preferred retinal locus. PREL training helps patients learn to use a healthier retinal area to improve function stability and visual performance. The study of the PREL can be done through indirect and direct searching methods. The microperimetry is the gold standard, but in the same places is not available. So we use standard automated perimetry, the macular program. So microperimetry is particularly useful because it allows precise mapping of retinal sensitivity, a fixation stability, and helping guide PREL training. But with the standard automated perimetry, we also screening a central visual field defects, and it helps us estimate functional visual performance of the central visual field and 10 degrees. And it's important for planning eccentric view training or assessment of visual performance before and after PREL stabilization through prismatic image relocation. What about practical rehabilitation strategies in clinical practice? So, in clinical practice, rehabilitation strategies may include eccentric viewing training to compensate for a central scotoma and improve visual stability and fixation control, a prismatic relocation to redirect visual input to functional retinal areas and reduction of metamorphopsia and central scotoma interference that patients referred as a blurred image at the center. Adaptation of the optical and electronic magnification devices, and reading speed rehabilitation and fluence training. In this image, we could see octopus perimetry with a macular program of one patient, one female patient with AMD. And above, we have the baseline perimetry of the right eye. And below, we have the perimetry with the two base out up prismatic image relocation that improve the mean sensitivity of the center of the visual field and could improve also visual acuity for distance and for near in reading ability and contrast sensitivity. In addition, low vision devices and environmental adaptation are very important after a PREL stabilization because the both of them contribute to improve reading speed, text navigation, and visual performance in daily living activities. Absorptive filters, it's also important in this patient because it enhances contrast sensitivity and glare control. And other environmental adaptations such as desk lighting, contrast enhancement, stair edges marking, large print materials, and the structured home organization play an important role in daily living activities of our patients. So, what is the key outcomes measures in low vision rehabilitation? It's very important about distance visual acuity after a rehabilitation program with PREL stabilization and low vision devices for magnification, distance visual acuity, reading speed, near visual acuity, and for me, contrast sensitivity is the main outcome in some tasks because it reflects visual performance in real world conditions. Document functional improvement following a PREL stabilization and magnification strategies is our main work in the rehabilitation program with our patients. Patient education is also a key component, important key component of rehabilitation. Patients should understand the disease, have a realistic expectation, and how to actively participate in rehabilitation program, because visual impairment and eye conditions, it's close related with general health and some of the risk factors. And it's important to integrate and promote eye health education about the modifiable risk factors. Lifestyle modification can also influence AMD progression. Important recommendation includes adherence to Mediterranean diet. There is associated with a lower risk of the progression to advanced AMD. Smoking cessation, regular physical activity, control of systemic disease, and protection from excessive sunlight. Reduced macular pigment optical density may be associated with the increased disability glare at outdoor environments or indoor environments, and it is common in individuals with AMD. Lutein supplementation has been shown to increase MPOD with associated improvements in visual acuity and contrast sensitivity. So a higher MPOD is strongly correlated with reduced disability glare. Selective absorption filters may be used as an adjunctive strategy, helping to improve glare control and overall quality of life in patients with AMD. To conclude, AMD causes functional vision loss behind visual acuity. Early referral to visual rehabilitation services, it's very important, is crucial. Integrating functional testing with structural imaging helps predict visual potential and tailored individualized rehabilitation programs. Effective care requires a multidisciplinary team. Low vision devices, training, environmental adaptation, and lifestyle recommendations provide the best outcomes of our patients, and patient education to improve health literacy and empower them are essential components of care. To resume, I would like to leave you with a sentence that for me it summarizes the approach presented here. In AMD care, early referral to visual rehabilitation together with healthy lifestyle strategies is essential to convert structural preservation into meaningful functional vision. Thank you very much for your attention. I would be happy to take any questions. Oh.
Well, Dr. Nadia, it was very interesting talk and focusing on the visual rehabilitation of this very challenging disease. And you have very clearly and in detail mentioned different approaches, how it can be managed, and patient can still use their available vision into their day-to-day activities. Just one thing, you are regularly managing these patients. What are the main problems these patients encounter in their these patients with age-related macular degeneration?
Okay, the main problems it's related with central scotoma, metamorphopsia, and reduced contrast sensitivity that consequently show difficulty in reading, face recognition, writing, and glare problems in outdoor.
Okay, so the other thing is you have mentioned about peripheral preferred retinal locus. That is something very interesting, and the use of prisms to utilize this preferred retinal locus. How important is this, and how successful is these patients are in using this preferred retinal locus with the help of prisms?
Okay, the PREL or preferred retinal locus acts as a new fixation point that allows patients to use healthier retinal areas for visual tasks. So through prismatic relocation, we could see an improvement in the reading, face recognition. It's about the visual function. So functional vision, we can see better values in one or two lines, and in the visual acuity for distance, for near, and contrast sensitivity. Reading ability, it's improved also. So I think the patient referred in the face recognition, a better face recognition is the first signal that PREL is stabilizing. So then we could measure through our tests, functional tests.
Okay. And what about these lifestyle changes you mentioned? How effective are these in rehabilitation, particularly nowadays of computer era, artificial intelligence, all these things? How much these are beneficial to these patients with the latest and current gadgets available?
Okay, I think it's very important because there is some evidence about the adherence to Mediterranean diet that decrease the risk of AMD progression in some stages. Sometimes the RED2 supplementation is recommended to our patients, mostly with the dry AMD and atrophic and AMD advanced in atrophic and intermediate to advanced to decrease the risk. A smoking cessation and a physical activity, and it's also important the systemic health control because the general health interfere in the vision health also. I think the patients want some information. It's very useful because I believe that we as a healthcare professional have the role to improve the health literacy between our patients. So I think we have a patient well informed. It's easier to have another development in the visual rehabilitation about the motivation and so on. I think it's different.
Well, Dr. Nadia, it was a very interesting talk, and you really explained in detail about the rehabilitation. We are ophthalmologists. We treat these patients using Avastin and all these things. But this is very important part of overall their treatment. As you mentioned, these patients should be referred early. Early referral and management starting, very crucial and very important. And I hope this presentation will be very beneficial to our international audience. They will learn from your experience and knowledge. I want to thank you on the behalf of our all international audience, and we are looking forward to more international sessions with you to learn from your experience and knowledge. Thank you, Dr. Nadia.
Thank you so much.